काम जो आप करेंगे
स्टूडेंट्स होंगे।
हाँ स्टूडेंट मेरा स्टूडेंट लिंक मंगाया है मैंने अभी, मेरा सिम डिलीट हो गया था फ़ोन से, मैं अभी आपको उस पर बढ़ाता हूँ फ़ोन, ऐसा अभी आपका चालू है।
अच्छा, क्वेश्चंस भी पूछेंगे,
वो
पूछ
उससे
सकते
लिख के पूछेंगे यहाँ पे ना, साइड से गूगल से ना वो यहाँ पे लिख के।
स्टार्ट करो।
हाँ
Good morning to all. I am Dr. Aditya Kumar Gupta, and this is the 8th semester class for approach to bleeding and coagulation disorders. I urge all of you to be safe during these times, and at the end of it I'll give you my email address, and you could also provide me one of your email address. I'll mail this PPT to that, and your questions if there are any. So as we know, bleeding and coagulation disorders a very important aspect in medicine general and also in pediatrics. So today we'll briefly just discuss about approach, what are bleeding disorders, what are coagulation disorders, and how can we differentiate each of these. So before we uh, before we dwell into each of these, just a brief overview of how hemostasis occurs. This is something which you have been taught even in your first year. So once there's blood vessel injury, some factors such as serotonin and also thromboxane, etc., are released, which are the neural factors that lead to the blood vessel constriction, and temporarily they lead to a reduced blood flow. Along with this, what happens is the collagen that is exposed, it comes into contact with the platelet surface. On the surface of the platelet there are receptors, 1b9 and 2b3a, and these then kind of interact with other receptors on other platelets, and it leads to a formation of a temporary platelet plug that is called the primary hemostatic plug. And now this temporary platelet plug, if it is not enshrined in a mesh, so it will be temporary, it will get dislodged. So that's why the coagulation cascade then has to take effect, and various factors that are released due to the damage and due to the contact to the surface lead to just a minute, hand. Okay. Lead to triggering of this coagulation cascade, which ultimately leads to formation of a fibrin mesh, and henceforth a stable hemostatic plug. Now this is electron microscopic view of the platelets as well as the endothelial cells, and once a damage has occurred, this is something that leads to early deposition and interaction of the platelets, leading to the formation of a primary hemostatic plug. So this is again an overview of the same: injury, collagen exposure, platelet adhesion, and release reaction that leads to release of serotonin, platelet phospholipids, etc. And thromboxane. Some of these factors mediate vasoconstriction, whereas others help trigger the coagulation cascade. There is formation of a platelet aggregation plug, and then which is then entangled in the fibrin mesh that leads to formation of a stable hemostatic plug. So this is again very well known to all of you, the coagulation cascade. So we have the intrinsic pathway, the extrinsic pathway, and then the common pathway. The intrinsic pathway, once there is contact of these factors with the surface, factor 12 is converted into 12A, which then converts 11 to 11A, 9 to 9A, and this is the this is 10 to 10A is the is the part that is common to both the extrinsic and intrinsic pathways. In the extrinsic pathway, tissue damage leads to conversion of factor 7 to 7A, and that again leads to conversion of factor 10 to 10A. Now 10A is important in the presence of factor 5 phospholipids and calcium for the conversion of prothrombin to thrombin, and thrombin then mediates conversion of fibrinogen to fibrin, which then leads to formation of a fibrin mesh, and then factor 13 to 13A, that is again mediated by thrombin. It is called the fibrin stabilizing factor, and it leads to formation of the stable fibrin clot. So once we know this pathway, it'll be very easy for us to kind of then understand why bleeding occurs. It could be related to the vessel, okay. Uh, the vessel is damaged and the constriction is not able to kind of give rise to that much effect so that the bleeding is taken care of. Happens in scurvy, ulcers, if there's a trauma, variceal bleeding, polyps, also in vasculitis. Platelet related problems are they could be primary due to the platelets per se, or secondary due to any other disease affecting the platelets. Now primary, the most common one is immune thrombocytopenic purpura, alloimmune thrombocytopenia found in neonates, and some intrinsic causes of low platelets such as thrombocytopenia with absent radii, Wiskott-Aldrich syndrome, platelet function defects such as Glanzmann's thromboasthenia, wherein the platelet numbers are normal, but the function, due to the various receptor defects, the function of the platelets is defective. So this does not encompass everything, but are some of the examples of primary platelet related problems that could lead to bleeding. Secondary problems could arise in platelets could arise due to malignancies, aplastic anemias, due to which there is not enough platelet production from the marrow. Drugs such as some antibiotics, cephalosporin groups, or such as some anti-epileptic drugs, they can lead to a decrease in the platelet production. Sepsis and DIC are secondary problems. And the coagulation problems, von Willebrand disease due to absence of defect in the von Willebrand factor, hemophilias that we are aware of, and secondary defects in coagulopathy could be due to liver disorders, drugs, DIC, or vitamin K deficiency. So with this background in mind, when we approach to a bleeding child, very important to know few things such as age of onset. So say I have a 2-month-old child who has come with bleeding. Okay, it's very likely that this could be something congenital bleeding disorder. It's not acquired, or it could be, say, vitamin K deficiency disorders, which are common. So age is important. Similarly, sex. Now hemophilia, if it's a female child, very unlikely. It's extremely unlikely it could be hemophilia, and uh, it's more common in males. So there is a sex predilection in certain disorders. Frequency of bleeding, so as to give an idea of the severity. Very low platelet counts, less than 20,000. The bleeding can occur spontaneously. Also, there could be life-threatening bleed, and it occurs very frequently. Location and type of bleeding. Certain disorders predict to certain locations, such as coagulation disorders. They would give rise to deep tissue hematomas, joint hematomas, whereas platelet disorders, mostly if there are not so severe, give rise to skin bleeds, petechiae purpura. Duration of bleed, for how long it has been occurring, so as to give an idea of the disorder. Say if it is very acute, occurring within a span of 2 to 3 weeks, then it could then disorders such as ITP in cases of platelets are more common. But say in the pretext of a jaundiced child who has had liver disease for 3 to 4 months, if there is bleeding, then it indicates that this could be secondary factor deficiency. Is the child on any medications such as anti-epileptics or vitamin K antagonists, as I said, could predict to certain disorders, and associated symptoms such as presence of hepatosplenomegaly or bony tenderness. These could predict that the child may be having a malignancy. So it's very important to take a very detailed history and do a systemic examination, because subtle clues can be obtained regarding the cause and the severity of the cause of bleeding. So when you examine such a child, apart from your routine vitals, it's very important to characterize the type, site, and severity of bleed. The type of bleed, whether it is deep tissue or superficial bleed or a mucosal bleed. The site of bleed, where it is it a deep intra-organ hematoma, or is it intraperitoneal, in which case it could be life-threatening and the child could go on bleeding. And the severity of bleed, This is indicated by certain factors such as the drop in hemoglobin or the amount of bleed that is visible per se. Other manifestations of underlying disease such as rash, indicative of many things. It could be there in malignancies, it could be there in infections, lymphadenopathy, anemia, renal and hepatic signs. So renal and hepatic disease can lead to secondary platelet disorders also, whereas hepatic disorders, chronic hepatic disorders can lead to coagulation disturbances. So this is petechiae, wherein they are pinhead size less than 2 mm. Purpura are larger, 2 to 5 mm in size, and this is ecchymotic patch, which is a large discolored patch, occurs due to intradermal bleed, and the ecchymotic patch is not elevated, it is flat with the surface and changes color as the time progresses. So coagulation disorders which are due to defect in the coagulation factors, and platelet disorders which are due to defect or less number of platelets, they have certain characteristics. They are not sacrosanct. Each could be found in in any of these, but skin bleeds are usually more common in platelet disorders. Ecchymotic larger ones are common in coagulation disorders. Scattered ones could be seen in platelet disorders. Soft tissue bleed more common in coagulation disorders. Joint hemorrhages are characteristic of coagulation disorders. Hemophilia, very characteristic joint bleeding. Delayed bleeding happens, say trauma has happened, initially the platelets would lead to formation of a primary plug, but then there would be delayed bleeding. That is more common in coagulation disorders. Bleeding from superficial skin abrasions, commoner in platelet disorders. Family history, again, coagulation disorders have a more family predilection. So these are kind of points that may guide you to a particular disorder, but these are not sacrosanct. So once you suspect that this child is either having a bleeding or a coagulation disorder, what are the battery of tests that you would order? So platelet count in the complete blood count is very important because it kind of excludes, at least this is not due to a quantitative platelet defect if the platelet count comes out to be normal. It could still be a platelet function disorder, but a quantitative platelet disorder, a defect is unlikely if the platelet count is normal on the complete blood count. And the gold standard for the platelet count is still the peripheral blood film. In the peripheral blood film, if you see a clump of platelets, that indicates that the platelet count is adequate. And the peripheral blood film will also give you certain clues, like if it's an infection, you could find activated cells, activated neutrophils shift to the left. If it is a malignant disorder, you could find a blast cell in the peripheral blood film, and that could give you a clue as to why the platelet counts are low. So here you can find large platelets. So large platelets, there are a group of disorders in which you find large platelets, such as Bernard-Soulier syndrome. So normally the small lymphocyte is about 7 micrometers, and here we can see the platelet size is much larger than that. It's about the size of the RBC. So so in this there is a qualitative defect in the platelet function, and it leads to bleeding. Similarly, here we can find an abnormal cell, a blast cell, and also notable is that in this peripheral smear there are no platelet clumps. There are no platelets to be seen. So this is a leukemia. The other tests that we then order are the prothrombin time, the activated partial thromboplastin time. I'll be coming to these in the subsequent slides, and the thrombin time. So as we know that the intrinsic pathway, extrinsic pathway merges to the common pathway and leads to fibrin generation. So the prothrombin time, it tests the abnormal prothrombin time, it tests the extrinsic pathway and the common pathway. So deficiencies or defect in factor 7, factor 10, factor 5, which is here, factor 2, that is thrombin, and fibrinogen, such as afibrinogenemia or dysfibrinogenemia, can lead to prolongation of abnormal prolongation of prothrombin time. The extrinsic defects, such as extrinsic factors that can lead to a abnormally prolonged prothrombin time, could be administration of heparin, warfarin, lupus anticoagulant, or in liver disorders. So the prothrombin time is usually, whenever you see the reports, it is expressed as a INR, International Normalized Ratio. So INR is calculated by the patient's prothrombin time divided by the control prothrombin time, and then the reagent that is used, it has an international sensitivity index that is labeled on the reagent. So you multiply with the ISI and then you get the INR. So depending upon various disorders, sometimes you have to administer anticoagulation in certain disorders, such as wherein there are stents are placed or there has been a thrombus. So the INR is targeted in between a particular range. So that's how the INR is calculated. The abnormal APTT could be due to defect in the intrinsic pathway and the common pathway. So factor 12, 11, 9, 10, these that you know of. And a very important group here is the hemophilias, 9 and factor 8. Defects in these can lead to abnormally prolonged APTT, and like I said for the extrinsic path, like I said for the abnormally prolonged PT, also abnormally prolonged APTT could be due to factors in the common pathway. Thrombin time is assessed when thrombin is added to the plasma and the clotting time is measured. It is affected by the concentration and reaction of fibrinogen. So it is a measure of how the fibrin stabilizing fibrinogen it forms the fibrin mesh, and the presence of inhibitory substances including fibrinogen, fibrin degradation product, and heparin affected. An increased thrombin time could be found in hypofibrinogenemia in the presence of fibrin degradation products, heparin, in the presence of heparin, or if there is hypoalbuminemia. Now this is something which is now with days it's getting more and more obsolete, something called the platelet function analyzer, wherein through a small hole platelets were passed and the time to the clot formation was assessed in the presence of a membrane coated with ADP, collagen, and epinephrine, which are otherwise essential for the coagulation cascade. And time to platelet adhesion, activation, and aggregation at the aperture in building a stable platelet plug was measured. And this was usually done in the presence of a normal platelet count, but if there was suspicion that bleeding is due to the platelets, then qualitative platelet disorders such as Glanzmann's thrombocythemia or Bernard-Soulier syndrome could be picked up by, the platelet function analyzer could give a clue to those disorders. Now coming to the second line tests for platelet disorders, bone marrow aspiration to look for whether there are megakaryocytes in the marrow adequate in number, whether it's a secondary infiltration due to malignancy or not. The morphology of platelets, whether it is large or small. Platelet adhesion tests done in the presence of various factors such as ADP, adrenaline, collagen, and analysis of platelet glycoproteins, etc. These are more advanced tests. And for the coagulation disorders, you measure the different factors such as specific measurement of the factor 8 or factor 9 in the suspicion of a hemophilia. Now we'll briefly discuss certain case scenarios. So this 3-year-old girl presents with sudden onset of bluish black spots. So these are ecchymotic spots over the body for the past 1 day. So 3-year-old and past 1 day, very acute. So unlikely it will be anything congenital. So it's happening at 3 years and it's acute. And the child has a history of flu-like illness 4 weeks ago, for which she received paracetamol and cetirizine. So these are very paracetamol, cetirizine. These are kind of very benign drugs. Not usually you would not associate any bleeding disorders with these drugs. On examination, she has multiple ecchymotic patches. What would you like to check on examination? So the answer to this would be, you would like to see whether this child also has any hepatosplenomegaly, bony tenderness, in which case you need to exclude malignancy. Otherwise, this is a typical scenario of immune thrombocytopenic purpura. And the child also had mild anemia, multiple petechiae, no hepatosplenomegaly, lymphadenopathy. On investigation, she was found to have a low platelets. Otherwise, her CBC was normal. The PT and APTT was also normal. So, would you do a bone marrow aspirate in this child? So, if you are suspecting immune thrombocytopenic purpura, not indicated. A bone marrow is not indicated. and unless and until there are certain signs which make you think this could be anything else, such as a malignancy, say if they have just palpable spleen in the presence of this scenario, then yeah, if you need to rule out a malignancy, you need to do a bone marrow aspirate. Would you transfuse platelets? And the answer again is no, because these platelets would get destroyed anyway. So if there are presence of mucosal bleeds or life-threatening bleeds, then the child could be started on IVIG and steroids, which take care of the autoimmunity. So this is a chart of various disorders which could be there in the presence of various scenarios, such as the one which we are discussing had a normal PT, a normal APTT, and a low platelets. So in this scenario, acute and chronic ITP are the more are the common possibilities which we had entertained in the previous case. And say a situation such as here, so a normal PT, abnormal APTT, and a normal platelet count. So the typical of the hemophilias, hemophilia A, hemophilia B, factor 11 deficiency. So this is a chart which you could go through. I'd be sending these slides to you, and you can go through. This is also available in various books. So the second case scenario, a 4-month-old child is brought to the emergency with bleeding post-circumcision, and in this child, what would you like to know? So 4-month-old, so indicative that this could be something congenital and post-circumcision bleeding. There's no significant history, other significant history. On examination, he has elevated heart rate, anemia is present, and there's no other positive finding. So when further tests are done on this child, the hemoglobin is a bit low, the TLC and platelets are normal. The APTT is isolated prolonged, so it's prolonged. The PT is normal. So isolated prolonged APTT in such a scenario makes you suspect a hemophilia. The next investigation would be ordering the specific measurement of the factor 8 and factor 9, and treatment would be supplementation of this child with the factors depending upon the degree of hemophilia, whether it is mild, moderate, or severe. Such a child comes with bleeding manifestations, and he has a large eye, so makes you suspect a malignancy. It's a presentation of AML. This is a myeloid sarcoma or orbital myeloid sarcoma, and this child had a elevated total leukocyte count. The platelets were also low. The PT and APTT were normal, and on the peripheral sphere we found abnormal cells with OR rods. So this is the diagnosis of AML. And in such a child, would you give platelets? So if the platelets are 60,000, platelet transfusion would not be indicated unless and until the child is bleeding. But once the platelets are less than 10,000, then prophylactic platelets are given. Otherwise, there is a risk of life-threatening bleed occurring. So thank you. I end my presentation here, and my phone number is 7838379837. I'll repeat it, 7838379837. You could WhatsApp me your questions on this number, and one of you could also send me your email IDs on this number, and I'll mail you this PowerPoint presentation. Thank you.
switch off my phone there. एक मिनट उसे खोलो कहाँ है डेस्कटॉप हाँ what is running why is there so many screens like this
उसको ऑन करो सर,
किसको
अपनी स्लाइड
हाँ ओके
आप चालू करो।
सॉरी
8 बजे से खत्म हो गया, 8 बजे
हो गया वो
खत्म हो गया। अब आपका चालू है, मैं चालू है।
It's already live. They didn't switch it off. I'll start it again.
स्टार्ट ऐसे होगा आपका।
Good morning. So, I know you're all in lockdown, as are we, and I want you to understand that this is something that is serious, which is why I put this personal chat on the screen for you. So, this is my friend who is working as a medical officer for the NHS in Brighton in UK, and she was tested at COVID positive last week, and this is what her condition is. And NHS is in such a bad shape that they do not have any medication, and what they're doing is just giving some homeopathic medicines and just supportive care. If you can see over there, the cost of one dose of chloroquine is more than £1,000, UK pounds that is. And therefore, please understand that the situation is actually serious. So there are going to be changes in the way that you're going to be learning things, the way that we are going to be teaching you things, and all the more reason why this is a time that you actually need to empower yourself for your education, something that I've been telling you again and again since the very beginning. Now, starting from today, I shall be dealing with about 4 lectures. They are dealing with the neuroanatomy as well as the gross anatomy of some cranial nerves. The 5th, 7th, 9th, 10th, 11th, and then I shall be dealing in the end with the cervical plexus and the autonomic nervous system of the head and neck. So that's going to be in the end. Now, yesterday I have already loaded my presentation on today's lecture as well as tomorrow's lecture, which is on the neuroanatomy of the 5th and 7th nerve today, as well as the gross anatomy of the 5th and 7th nerve tomorrow. The reason I've clubbed them together is that they actually work quite well together. And if you have had the time to go through the presentation, you'll understand that it's pretty straightforward and it's pretty simple. And along with that, what I've also done is that I've loaded 2 quizzes, one for today and half of one for tomorrow. And these quizzes are formative questions. You can attempt them as many number of times as possible, and it has been derived from material that is already there in these presentations, as well as you will be directed to read and learn certain important aspects that would be there from either your books or from the internet, as the case may be. So please use the Saral platform. When I logged in yesterday, I saw that there are 135 participants, which includes your teachers as well as your residents. and most of you have your login, they're active. So please use it. Look at the material that are going to be uploaded on them. Do the quizzes, they will help you to learn the subject. And please don't think that those quizzes are going to come in your exam, because these are formative questions. Formative questions are a method of revision and also a method for you to understand how much you have learned. These are not summative questions which would have an element of analysis behind it, where we try to understand how much have you learned, okay? So starting with what is there today, that is the neuroanatomy of the fifth and seventh cranial nerves. So these are the objectives with which we are going to be going through. First and foremost, I shall be giving you again a repetition of what are functional columns or functional components. Then we shall be dealing with the nuclei and tracts that are related to the sensory and motor aspects of the fifth and seventh nerves. And we shall be dealing with some sensory motor reflexes of the head and neck, which are actually related to the fifth and seventh nerves, and certain applied aspects. Now, before we actually get on to the hardcore part of this lecture, it becomes important to understand what is somatic innervation and autonomic innervation. So you can see the base of the brain over here, which you've already seen when the brain was delivered out of the cranial cavity, and you can see the cranial nerves that are attached to the brainstem as well as parts of the diencephalon. So the optic nerve, oculomotor, trochlear, trigeminal, abducens, the 7th and 8th, then the series of 12, then 9, 10 and 11. And further, there are also components of the cervical plexus which are going to be formed by the ventral rami of the cervical spinal nerves. Now, this somatic innervation of the head and neck is dealing with those structures that have developed from somites, or those structures that have developed from pharyngeal arches that develop in this region. When it comes to sensory components, it deals with general sensations like pain, temperature, crude touch, pressure, proprioception, all of them related to structures that have developed from either somites or from the pharyngeal arches. Now, when you go to the autonomic innervation, that is the innervation which are meant for viscera. So it would have the sympathetic component as well as the parasympathetic component. You know that the sympathetic outflow is essentially thoracolumbar. That means the first neuron of the sympathetic outflow is found in the intermediolateral or the lateral gray column within the spinal cord. And from there, the gray rami, which are carrying the preganglionic fibers, the white rami which carry the preganglionic fibers, enter into the spinal nerves and the sympathetic chain. So technically, when we reach the cervical segments or the cervical spinal nerves, there is no more first order neurons that are coming directly from the spinal cord. Therefore, the fibers that are there in the sympathetic chain, they give gray rami to individual spinal nerves, so that from head to toe you have innervation which is derived from the sympathetic thoracolumbar outflow. Whereas for the parasympathetic, you know that their first neuron is found in either the cranial part or related to cranial nerves or in the sacral segments, and the sacral segments you saw is S2, 3 and 4. In the cranial part, you know that they are related to 4 nerves in particular, 3, that is the oculomotor, the Edinger-Westphal nucleus. Then you have it related to 7, 9 and 10, and you know that 10 or the vagus extends right up to the level of the midgut, the end of the midgut. Now, the ganglia of the parasympathetic system are found as close to the organ as possible, and there are some important ganglia that are there related to the head and neck. When you discuss the orbit and saw the dissection of the orbit, you would have heard of the ciliary ganglion, which is related to the oculomotor nerve, but physically related to the ophthalmic division of the trigeminal. Now, related to the maxillary nerve is another ganglion which is known as the pterygopalatine ganglion, and you can see that it lies between the posterior surface of the maxilla and the pterygoid process of the sphenoid. So that is why the name of this ganglion is also pterygopalatine ganglion, because it lies in the pterygopalatine fissure or pterygopalatine fossa. A third ganglion is related in the temporal region, related to the mandibular division of the trigeminal nerve. And this is the otic ganglion, which is related to the innervation of the parotid gland. And finally, again related to the mandibular division of the trigeminal nerve is a submandibular ganglion, which is related to the lingual nerve, and it supplies the submandibular gland and the sublingual glands. So this is just an overview about the somatic and the autonomic innervation of the head and neck region. Now, before we start anything, I would like to repeat again and again that the prototype on which you base the learning of neuroanatomy is always the spinal cord. The reason being that almost everything is actually covered. About 85 to 90% of neuroanatomy can be covered by just the spinal cord. If you trace individual tracks and then go through their various neural stations and their connections, you would have learned most of the spinal cord, whether it be the basal nuclei, the cerebellum, parts of the cerebral cortex, and so on and so forth. The only parts that may be left out would be some small parts like the limbic system or some parts of the hypothalamus, which are particularly related to the autonomic nervous system, and so on. Now, when it develops, you would have heard of the neural tube having two collections of neurons, one towards the ventral aspect, that is the basal plate, and one towards the dorsal aspect, which is the alar plate, and both of them bulge into the neural tube such that it forms a sulcus between them. So this is the alar plate and this is the basal plate, and between them is the sulcus limitus. Now, what has been determined is that this alar plate normally gives rise to interneurons and sensory neurons, whereas the basal plate gives rise to interneurons and motor neurons. So these further split in the spinal cord to give rise to four functional columns, that is, from dorsal to ventral, general somatic afferent, general visceral afferent, general visceral efferent, and general somatic efferent. Now, if you just see what I have written over here, the general somatic afferent is meant for general sensations from the skin, that is touch, pressure, temperature, pain, proprioception, and so on. General visceral afferent is for general sensation from the viscera, that is stretch, pressure, chemical and osmotic changes, like the baroreceptors, as well as the osmoreceptors that you get related to various viscera and even blood vessels. Now, general visceral efferent is what is going to be innervating the viscera. So that would be under the sympathetic and parasympathetic components, which will provide innervation to not only the smooth muscles but also secretomotor fibers to glands. And the general somatic efferent is for the innervation of striated muscles, which are derived from somites, which are the paraxial mesoderm, giving rise to the myotome. Okay? Now, what happens in the head and neck region is that apart from the general development of the body, that is the trunk and the limbs, around the oral cavity we get the development of the pharyngeal arches. And each pharyngeal arch, so if you can see over here, this is a folded embryo, which is the head fold. This is the area of the oral cavity or the stomodium, which has been surrounded by the pharyngeal arches. You can see there are 6 pharyngeal arches, of which the 5th disappears very soon. And if you cut a section through the head and you take this portion off and you are left with the floor, this is what you get. This is the floor of the pharynx, or the floor starting with the oral cavity and the front of the pharynx. And you can see each of these arches has got a muscular component, a skeletal component, a nerve and an artery. So these muscles are also striated muscles, but they do not develop from the somites of the paraxial mesoderm, but they actually develop from neuroectoderm. And the parts of the neural tube that come and innervate these, either for the sensory aspects or the motor aspects of the pharynx and structures related to it, they develop from a separate group of neurons, and which is why they are known as special. And you can see that now, instead of 4 functional columns, what we get are about 7 functional columns in the region of the brainstem. In the region of the brainstem. And these functional columns, if you start from lateral to medial, would be the special somatic afferent, which is meant for sensations like hearing and balance. Then we get the general somatic afferent column, which is again the same as what you got in the spinal cord for general sensations like pain, temperature, pressure, touch, proprioception, and so on. Then special visceral afferent. Now these are special sensations that have only developed in the region of the pharyngeal arches, like taste, which you don't get anywhere else. Okay, so then that is a visceral sensation, and therefore that comes under the special visceral afferent column. And close to the sulcus limitans is again the general visceral afferent column, which is general sensation from the viscera like stretch and pressure and chemical and osmotic changes. Now medial to the sulcus limitans, which would be part of the basal plate, again symmetrically we get general visceral afferent column, which is meant for efferent column, which is going to be meant for the parasympathetic and sympathetic innervation of the viscera. Then we have the special visceral efferent column. Now this is for all the striated muscles that have developed from the pharyngeal arches. That means there are 6 pharyngeal arches. So the neurons or the motor neurons that are going to be innervating muscles that have developed in the first arch, second arch, third arch, fourth arch, and sixth arch, they belong to this. Okay? And finally, we get the somatic efferent column, which is meant for somatic striated muscle, that is those that have developed from the paraxial mesoderm. Okay? Now, the nerve of the first arch or the ganglion of the first arch is a trigeminal, so that is special visceral efferent. For the second arch, it is facial. For the fourth and the sixth, it is going to be related to the cranioaccessory complex or the vagoaccessory complex, and the third arch is the glossopharyngeal. So they all have specific nuclei that are going to be related to it. I'm going to show you that. Now this is again something that you've already seen. On the left side are the sensory nuclei, and on the right side you have the motor nuclei. Now I'll finish with the sensory. Very simple. You've got 3 sensory nuclei which are predominantly belonging to the trigeminal complex, which is the mesencephalic, the principal sensory. Mesencephalic is in the midbrain, principal sensory is in the middle of the pons, and the spinal nucleus of trigeminal, which reaches up to almost the C1, C2, C3 levels. So this is related to somatic afferent, the general somatic afferent, that is the trigeminal nucleus. The other nucleus, which is on the sensory side, is the nucleus of Tractus solitarius, which has got a cranial part which is found near the pontomedullary junction, or actually the lower pons, and a medullary part which is extending right up till the area of the pyramidal decussation. So this is the solitary tract, the nucleus of the solitary tract. So the cranial most part or the rostral part of this solitary nucleus is related to taste. So this is known as the gustatory nucleus, which is special visceral afferent column. So anything related to taste comes over here. Whereas the rest of the solitary tract is going to be the general visceral afferent. That means general sensations from the viscera right up to the midgut is actually relaying over here, that is in the caudal part of the nucleus of solitary Tractus solitarius. Now closest to the midline is the somatic efferent column. Somatic efferent column means those muscles that have developed from, supplying those muscles that develop from the paraxial mesoderm. So that is oculomotor, trochlear, abducens, as well as the hypoglossal. All of them are supplying skeletal muscle that have developed from somites. In between, you also get the parasympathetic nuclei. The parasympathetic nuclei related to the third nerve is Edinger-Westphal nucleus. The one that is related to the 7th and the 9th nerve is the superior and inferior salivatory nucleus. and the one that is related to the 11th and the 10th nerve is the dorsal motor nucleus of the vagus. Now, there are also those nuclei which are related to supplying muscles that have developed from the pharyngeal arches. So here we have the motor nucleus of trigeminal, then the motor nucleus of the facial, and related to the 9th, 10th and 11th nerves which are supplying the muscles that have developed from the 3rd, 4th and 6th arches, we've got the nucleus ambiguus. So this in general summarizes all the functional columns that are available right from the midbrain right up to the medulla. And at each level, depending on which cranial nerve and what are the components or columns related to it, you will be able to understand which nuclei are going to be contributing to it. So this table is just summarizing which all nerves contain which all columns. So you can see there are 7 columns, and these are giving you the cranial nerves to which they are contributing. And you can see that I have encircled all those columns in which we can see the 5th and the 7th nerves, which is related to today's lecture. So 5th and 7th have got general somatic afferent, 7th has got general visceral afferent as well. General visceral efferent is there again in the 7th, and then special visceral afferent is found in the 7th, which is taste, and special visceral efferent is found in both 5th and 7th, that is motor innervations of muscles developed from pharyngeal arches. Okay. Now coming to the trigeminal nerve nuclei. So the trigeminal nerve nuclei complex consists of a motor nucleus, which is meant for muscles that are developed from the first pharyngeal arch, and sensory nuclei. So the sensory nuclei are 3 in number. You've got the chief or the principal or the pontine trigeminal nucleus, which is found in the mid-pontine level. Then you have the spinal nucleus, which has got 3 subparts, and it extends right from the mid-pontine level to the level of C2, spinal segment, cervical 2 spinal segment. And we also have a mesencephalic, or a component of the sensory nucleus, which is found in the midbrain, which is called mesencephalic. But unlike the other sensory neurons, this is actually a first order neuron, which is very similar to what the dorsal root ganglion is for the spinal nerves, and this is meant for proprioception. So this is the only first order neuron which is found in the central nervous system. Otherwise, all first order neurons are found in the peripheral nervous system within the dorsal root ganglion or the ganglia related to cranial nerves, like the trigeminal ganglion which you saw in the middle cranial fossa. So when you look at the sensations that are related to the spinal or the trigeminal nucleus, you can understand that for the general sensations, their first order neuron are found in the trigeminal ganglion, which is there in the middle cranial fossa, except for proprioception, where the first order neuron is going to be found in the mesencephalic nucleus of the midbrain. So if this is the first order neuron, you can understand that there is going to be a peripheral process that goes to the receptors and a central process which goes towards the second order neuron. And you know that usually second order neurons are going to cross the midline. Now if you look at the trigeminal ganglion, you can see that the peripheral processes are going towards the receptor. Let's look at the central processes. The central processes, they enter the brainstem and they either ascend or descend. If they are ascending, they reach the central chief sensory pontine nucleus, which is there in the pons, middle of the pons, or they descend right onto the surface of the spinal nucleus of trigeminal, which is extending from the pons right up to C2 level. So these fibers are what are forming the tract, the spinal tract of the trigeminal nerve. So that means the spinal tract of the trigeminal nerve, which you can see on the surface of the medulla, is actually carrying fibers that are ipsilateral. They synapse on the spinal nucleus, and from there they cross the midline onto the opposite side and form the trigeminal lemniscus. And you know that the trigeminal lemniscus lies medial or ventral to the medial lemniscus and the spinal lemniscus. Now, what happens to those that are there in the principal pontine nucleus? Here, again, there is a synapse on the second order neurons, and from there they either go on to the opposite side as a ventral trigeminothalamic tract, or they continue on the same side as the ipsilateral dorsal trigeminothalamic tract. So the trigeminal nucleus, the second order neurons, can either have an contralateral component or it can have an ipsilateral component. The ipsilateral component forms the dorsal trigeminothalamic tract, and the contralateral component, which is the majority, forms the ventral trigeminothalamic tract. And once both of them join together on one side, that is how they form the trigeminal lemniscus. So trigeminal lemniscus, which lies medial to the medial lemniscus, contains both the ventral trigeminothalamic as well as the dorsal trigeminothalamic fibers. And from there they go on to a nucleus of the thalamus, which contains the third order neurons, which is the VPM. Now you know that spinal as well as the medial lemniscus synapse at the VPL, that is ventro-posterior lateral nucleus of the thalamus, whereas the trigeminal lemniscus synapses with the ventro-posterior medial nucleus. So VPM is meant for trigeminal lemniscus, whereas VPL is meant for spinal lemniscus and medial lemniscus. Okay? And from there, the third order neurons will project towards the area 312, or the primary sensory area, which, and that too you know that this will be in the lower part, lower lateral part of the post-central gyrus, which represents, if you remember the homunculus, the area for the face, head and neck and the face, right? And so in the inverted homunculus, the area for the head and neck and face comes in the inferolateral part of the postcentral gyrus, which is supplied by the middle cerebral artery. Whereas the portion that is meant for the lower limb and the perineal region is supplied by the anterior cerebral artery, right? Okay. Now, there is a lot of correspondence of the tracts that are meant for the head and neck with what you see in the spinal cord as well. So now you know that for the spinal sensations, that is proprioception, that is conscious proprioception, they travel in the dorsal column, whereas touch and pressure, and pain and temperature, they travel with the spinothalamic tracts. And you know that the second order neuron for pain, touch, temperature and pressure, they lie in the nucleus proprius, or the tract cells, from where they cross the midline and form the spinothalamic tracts, right? And you know that the substantia gelatinosa and the nucleus proprius are meant for these second order neurons. Now, corresponding to the substantia gelatinosa is actually, and the nucleus proprius, is the spinal nucleus of the trigeminal. And you know that this picture is extremely important for you, which shows you the dermatomal distribution of the three different divisions of the trigeminal nerve: the ophthalmic division, the maxillary division, and the mandibular division. And each of these is also related to the development of these regions. So ophthalmic is related to the frontonasal process, the maxillary is related to the maxillary process of the first arch, and the mandibular is related to the mandibular process of the first arch. I will discuss that later. Now, if you look the pathway for pain and temperature, that means corresponding to the spinothalamic tract. If you look at it, the first order neuron is found in the trigeminal ganglion, and from there it actually goes down to the lower part of the spinal nucleus, crosses to the opposite side and goes to the VPM, and from there to the postcentral gyrus. Now, there is a certain somatotopy that is related to it. That means the portion that is meant for the ophthalmic fibers, that is sensations that are coming from the this region are going to be lying laterally and ventrally, whereas the ones that are meant for the facial glossopharyngeal vagus as well as the mandibular part, that is this portion, that means the lower part of the face, that is found more dorsally. That is found more dorsally and medially. Okay. So there is a somatotopy, and you can understand that the pain and temperature fibers go to the most caudal part of the spinal nucleus of trigeminal. Now, this is important because this is the region that is supplied also, that means in the lower part of the medulla, lower lateral part of the medulla, this is the region that is supplied by the posterior inferior cerebellar artery. And therefore, loss of pain and temperature on the same side of the face is a characteristic feature of the lateral medullary syndrome or the Wallenberg syndrome. Okay, so there is ipsilateral loss of pain and temperature on the face, whereas contralateral loss of pain and temperature of the opposite side of the body, and that is why dissociate anesthesia is a characteristic finding in lateral medullary syndrome, where the artery that is affected is usually the posterior inferior cerebellar artery. Now, for touch and pressure, that is crude touch and pressure, the first order neuron is again in the trigeminal nucleus, and here the second order neurons are found in the more cranial part of the spinal nucleus of trigeminal, and then they cross to the opposite side. Whereas fine touch and pressure, that is discriminatory touch, that goes to the principal sensory nucleus. And this also contains the second order neurons for proprioception, conscious proprioception in this region. Now, proprioception is slightly funny in the head and neck region because it is just an extension of crude touch and pressure. So, I will not go into the details, that is mainly for the postgraduates, but you must understand that proprioception second order neurons are also there in the principal sensory nucleus, and from there they either cross to the opposite side as the ventral trigeminal thalamic tract, or they continue on the same side as the dorsal trigeminal thalamic tract, and both of them together form the trigeminal lemniscus. Now, this is there in the upper part of the medulla, and therefore in a lower medullary problem you normally do not get a lot of effect of the crude touch and pressure sensations, whereas in a lateral medullary syndrome the loss of pain and temperature in the area of the head and neck on the same side is characteristic. Okay. Now, what about the motor component? The motor component lies medial to the main principal sensory nucleus of the trigeminal. It has about 7,000 to 8,000 neurons, and the fibers, they go out medial and ventral to the sensory component of the trigeminal when it comes out of the pons, and there it goes and supplies all the muscles that are developed in the first arch, which includes the muscles of four muscles of mastication, that is temporalis, masseter, lateral pterygoid and medial pterygoid. And then it also supplies the other muscles that have developed from the first arch, that is mylohyoid, which you saw on the floor of the oral cavity. Then you have the anterior belly of digastric. This is again something that you saw yesterday in the dissection of the anterior triangle. In the digastric triangle, you would have seen that the submental triangle, you would have seen these two muscles, the anterior belly of digastric and the mylohyoid. These two muscles are two tensors that are related to the first arch, that is the tensor tympani and the tensor veli palatini. This is also derived from the first arch. So there is a reflex that is related to this nucleus, and that is a jaw jerk, which is a monosynaptic deep tendon reflex, like you have the knee jerk for the lower limb, or the biceps tendon jerk, which you elicit at the elbow. You would have done that in physiology. So this is known as a jaw jerk, where we tap on the lower jaw, and the same way as you tap on the tendon of the quadriceps, and when you tap on it, the lower jaw closes. So that is known as the jaw jerk. So here the afferent limb is coming from the muscle spindles around the masseter, and the center for the reflex are the pseudo-unipolar neurons which are found in the mesencephalic nucleus, which sends some collaterals to the main principal sensory nucleus, but it sends direct synapses. It has direct synapses with the bilaterally with the motor nucleus of the trigeminal, which is why both sides the masseter contracts, and that is why symmetrically during the jaw jerk the mouth closes. It is not a unilateral reflex, it's a bilateral reflex. So the center is actually the mesencephalic nucleus of the trigeminal, and it's a monosynaptic reflex at between the mesencephalic nucleus as well as the motor nucleus of the trigeminal on both sides. Okay, so this is the jaw jerk. It looks and verifies as to whether the midbrain nucleus of the trigeminal is intact. So therefore, in a midbrain lesion where you could have problems with the level of either the trochlear nerve or the oculomotor nerve complex, you can also elicit the jaw jerk to verify as to whether even the ventral part of the tegmentum in the midbrain is intact or not, because this is there in the ventral tegmentum of the midbrain. So if you understand what are the functions of the trigeminal nerve, you will be able to easily identify its connections. So you can look these up in the book. So there are going to be motor connections as well as sensory connections to the nucleus directly. So these are fibers that are coming into the nuclei. So the motor definitely is going to be having connections from the corticonuclear fibers, that is the upper motor neurons which are meant for the motor neurons, or the lower motor neurons which are forming the motor nucleus of trigeminal. And these motor neurons are also getting collaterals from the sensory trigeminal neurons, that is including the mesencephalic nucleus, the red nucleus, reticular formation, from the tectum, the medial longitudinal fasciculus, locus coeruleus, and the sensory nuclei also getting afferents from the nucleus ambiguus, the other cranial nerve nuclei, the superior olivary nucleus, inferior olivary nucleus. All of these help in coordinating activities of the head and neck with respect to both the sensory activity as well as the motor activity related to the trigeminal nerve, that is mastication. So that means you start masticating when you have the sensations in the oral cavity, which is why it is mandatory that it has got connections with other cranial nerve nuclei. Okay, and the efferent connections are going to go first and foremost, most importantly, to the thalamus, which is the VPM, and that too bilaterally. Then it will also have connections with the cerebellum, the periaqueductal gray, the parabrachial pontine nuclei, which are part of the reticular formation. It also has connection with the spinal cord and also the motor nuclei of other cranial nerves, including the salivatory nucleus, because again you know that if there is sensation in the region of the head and neck, that also leads to salivation. That is your own personal experience also, I'm sure. So these are some reflexes that are related to the trigeminal nerve, where trigeminal nerve works as the afferent. The jaw jerk is the only monosynaptic deep tendon reflex that is there. The others are polysynaptic sensory reflexes like the corneal reflex, the sneezing reflex, and the oculocardiac reflex. And the corneal reflex, so if there is some foreign body that comes near the cornea or touches the cornea, immediately you start blinking. So that is the corneal reflex. If there is an irritation in the area of the nose or the nasopharynx, you start sneezing. So that is also mediated by afferents from the trigeminal nerve. Oculocardiac reflex is an interesting reflex because if you apply pressure, deep pressure on the eyeballs, that can lead to the stimulation of the vagus and a slowing of the heart. So this is also used as a clinical method by which a person with severe tachycardia, if you do not have any form of medical intervention, either you can do a massage of the carotid baroreceptor or you can do a deep eye massage to stimulate the oculocardiac reflex and bring down the heart rate, because that will work as a cardio inhibitor. these are some of the applied aspects of the trigeminal nerve, which is related. This I'll deal with also with the gross anatomy in scalp surgery, why it is necessary to give general anesthesia instead of local anesthesia whenever you are suturing or doing any surgery on the scalp. And then there is this extremely painful condition known as trigeminal neuralgia that is also related actually to the trigeminal ganglion more than the central nervous system component of the trigeminal nerve, and therefore I shall deal with that also with the gross anatomy. More importantly, this is something that I've already discussed, these two aspects, that is dissociate anesthesia of the face, which is found in the lateral medullary syndrome, and the oculocardiac reflex, which is a polysynaptic reflex, which is connection between the trigeminal nucleus and the dorsal motor nucleus of the vagus. Now, coming to the facial nerve. The facial nerve has a motor component. It has a parasympathetic component, that is general visceral efferent component, and it also has a sensory component, both for taste, that is special visceral afferent, and also general somatic afferent, where the skin, a small part of the skin of the external ear in the external auditory canal is supplied by a small tiny branch of the facial nerve. Okay. This parasympathetic innervation is meant for many, and actually most of the glands of the head and neck, that is the lacrimal gland, the submandibular and sublingual glands, and the mucosal glands of the nose, palate, and the upper pharynx. So all of these glands which are related to the viscera, including the lacrimal gland, are supplied by the salivatory nuclei, which is the general visceral efferent component. And the motor innervation is to all the muscles that have developed in the second pharyngeal arch, which is the muscles of the face, scalp, and ear. So you've already done the dissection of the face where you saw the frontalis, occipitalis, the levator, labii superioris, and all those fancy names. So all of them are part of the second arch muscles. In addition to them, there is this muscle that is there in the ear, middle ear, which is known as stapedius, which is connected to the footplate of the stapes, which covers the oval window. And this muscle helps in pulling the footplate so that it doesn't move too much, and this works as a part of a reflex to loud sounds, sudden loud sounds, so that the movement of the fluid inside the cochlea is not so much that it is going to damage the inner ear, the components of the inner ear and its receptors. So this is a protective muscle which reduces the movement of the footplate of the stapes. So this is an extremely important part of a reflex, protective reflex of the ear. So this is the stapedius. This is also supplied by the second arch nerve, which is the motor nucleus of facial. And it also supplies the posterior belly of digastric and the stylohyoid. Again, these are muscles that you saw yesterday in the dissection of the neck. So if you remember from the trigeminal, the anterior belly of digastric actually develops from the first arch and is supplied by the mandibular nerve, whereas the posterior belly of digastric develops from the second arch and is supplied by the facial nerve. So this is something that you must remember. Digastric, both parts have got two different nerves supplying it. So the anterior belly from first arch, mandibular nerve, and posterior belly, second arch, and facial nerve. Okay. Now, these are the nuclei that are related to the facial nerve. So you've got three nuclei: the motor nucleus, the nucleus of tractus solitarius, and the superior salivatory nucleus, which are all contributing to the facial nerve fibers that are going to be coming out. It has got two roots. It has a motor root as well as a sensory root. So the motor fibers are going to be coming out and the sensory fibers are going in. So for these sensory fibers, where are the first order neurons? So the first order neuron is actually found in the geniculate ganglion, which is a sensory ganglion for, or the peripheral root ganglion, which is meant for the facial nerve sensations, the sensations that are related to the facial nerve. And there are also multiple parasympathetic ganglia that are related to the facial nerve, like the pterygopalatine and the submandibular ganglia. Now, so these are the functional columns that are related to them. The motor is special visceral efferent, that is muscles developing from the second arch. The sensory is special visceral afferent, that is taste from the anterior 2/3 of the tongue and the palate. Now please pay attention to this. This is meant for the sensations that are there on the taste buds of the anterior 2/3 of the tongue except the circumvallate papillae. So if you see the anatomy of the tongue, I would like you to go and see pictures of the anatomy of the tongue. You will see that there is an anterior 2/3 of the tongue and a posterior 1/3 of the tongue, which are separated by a sulcus limitans. However, the circumvallate papillae, they lie anterior to the sulcus limitans, so technically they are part of the anterior 2/3 of the tongue. But their taste sensation, that is the special visceral afferent component of taste from the circumvallate papillae, are actually carried by the glossopharyngeal nerve. So this taste from the anterior 2/3 of the tongue does not include the circumvallate papillae, which is actually carried by the glossopharyngeal nerve. I will deal with that in detail with the 9th nerve. Then there is a secretomotor component, which is the general visceral efferent or the parasympathetic component, which is meant for submandibular sublingual glands, the lacrimal gland, and also the glands of the nose, palate, and the upper pharynx through the pterygopalatine ganglia. Then there is a tiny component of general somatic afferent as well, which is general sensation from the external auditory canal as well as the proprioception from the facial muscles, which is going to be going towards the nuclei of the trigeminal nerve. Right. Now, the facial nucleus, technically if you look at the floor of the fourth ventricle, if this is the abducens nucleus, that is the somatic efferent column, the facial should have been just lateral to it, over here. Right? Because you know that close to the midline is a somatic efferent column, and immediately lateral to that is a special visceral efferent column, and close to the sulcus limitans should have been the general visceral efferent column, and then you get the sensory components. Now, when you look at the section of the brainstem, which you've already done in your neuropractical 1 as well as the neuropractical 2, you would have identified the facial motor nucleus way anterior inside the tegmentum of the pons. Right? So if that is the case, why does it move this way? So that means it should have been located here, but it actually comes and lies over here. So this migration of a nucleus from its original position to a more definitive later position is known as neurobiotaxis. And this migration, that is from medial, so this would have been the original position of the facial nerve and the fibers would have been coming out like this. So this migration has taken place around the abducens nucleus. It goes close to the midline and then it comes out and lies over here inside the tegmentum ventrally. So why does it happen like this? There are multiple theories that are related to this. You can read about it, but what I'm more concerned about it is that you can see that the fibers of the facial nerve have migrated ventrally, medially, and caudally to come and lie in the tegmentum, in the anterior part of the tegmentum. So this phenomenon is known as neurobiotaxis. Okay, so this neurobiotaxis is a phenomenon that can be seen with respect to the facial nerve, and when it does this, the nucleus, that means this is where the nucleus is, the fibers are going around the abducens nucleus and coming out at the pontomedullary junction, at the cerebellopontine angle, right? So when it does this, you can see that it is forming a turn around the abducens nucleus. So this turn around the abducens nucleus is known as the internal genu of the facial nerve. Now we are talking about the facial nerve. It's not the facial nucleus, it is the facial nerve. So these fibers that are turning or winding around the abducens nucleus, they raise an elevation on the floor of the fourth ventricle, which you've all seen as the facial colliculus. So facial colliculus is actually raised by the abducens nucleus and the fibers of the facial nerve, that is the internal genu of the facial nerve, which are winding around the abducens nucleus close to the midline. So that is the facial colliculus that you saw on the floor of the fourth ventricle. just medial to the sulcus limitus in the pontine region, right? And after that it comes up. Now look at the sensory component. The sensory component, as I told you, are pseudo-unipolar neurons which are found in the geniculate ganglion. The peripheral processes go towards the receptors, and the central process either goes to the trigeminal complex or it goes into the solitary nucleus complex. So the taste fibers are going to the solitary nuclear complex, whereas the general sensation of pain, touch, pressure, temperature, all of that are going to the spinal nuclear complex, okay, the trigeminal nuclear complex. And this is the peripheral distribution of the facial nerve, where you can see that once it forms the common facial nerve, that is the motor root as well as the sensory roots, they've joined together. The sensory root as well as the parasympathetic root are known as the nervous intermediate. They join together inside the internal auditory meatus to form one common common facial nerve. Now where it forms, soon after that, it enters the petrospartotemporal bone, and over there it forms a ganglion which is known as a geniculate ganglion. And it is in the geniculate ganglion that you get the pseudo-unipolar cells of the facial nerve, which is the first order neuron for sensations related to the facial nerve, right? Now, at the geniculate ganglion, it gives off a branch which is known as a greater petrosal nerve, which contains one component of the parasympathetic fibers and also some sensory fibers. Then, it goes around a part of the internal ear which is known as a promontory, and over there, the promontoric part, it gives off the motor branch to the stapedius muscle. This is extremely important. You please understand why I am telling you this. This location of these branches, that means greater petrosal nerve which is got parasympathetic as well as some sensory components which is given off at the level of the genicular ganglion or the geniculate ganglion. At the promontoric part, it gives off the branch to the stapedius, which is the motor fiber. Then further down, before it exits out of the stylomastoid foramen, just about 5 to 6 millimeters proximal to the stylomastoid foramen, it gives off a branch which also contains a sensory component and the parasympathetic component, which is known as a chorda tympani nerve. It is called chorda tympani because it lies inside the middle ear cavity, which is known as tympanum or the drum. And this nerve, again, I'm repeating, has the sensory component as well as the parasympathetic component. The parasympathetic component meant for submandibular ganglion, and the sensory component, which is taste, for the anterior two-thirds of the tongue, excluding the circumvallate papillae. And if you look at the greater petrosal nerve, here the parasympathetic component is meant for the pterygopalatine ganglion, which is meant for the lacrimal gland and the glands of the nasal and pharyngeal mucosae, and the taste sensations from the soft palate and the hard palate, the mucosa that is found over there. Okay. Now, once it comes out of the stylomastoid foramen, it gives mainly motor branches, and you've seen those branches during your dissection of the face, where these branches come out of the anterior border of the parotid as temporal branches, zygomatic branches, buccal branches, mandibular branches, and cervical branches, which are supplying the muscles of facial expression. And the posterior branch, it goes and supplies the occipitalis and some muscles which are found around the external ear, and also a sensory component which is supplying the skin of the external ear near the floor of the external auditory canal. So this is the peripheral distribution of the facial nerve. Now, this is just a repetition of the same thing. Now, this is important, and I shall be repeating this cursorily tomorrow as well, the parasympathetic innervation related to the facial nerve, which is the general visceral efferent. Now, if you see this picture, you can see where it starts, that is the superior salivatory nucleus is related to the facial nerve. So this is where the first order neuron is. Now, what you see as points over here are all neural stations without forming any synapses. So the synapse is actually formed in the peripheral ganglion. On one side, either the pterygopalatine ganglion, or on the other side, the submandibular ganglion. And from there again you can see these points or nodes which are just neural stations or nerve fibers through which they are going to be traveling for the palatine glands, nasal glands, lacrimal gland, the sublingual gland and the submandibular gland. Now let's just take the simple pathway first. So you've got the superior salivatory nucleus. So the fibers are coming out of the superior salivatory nucleus. So these are the preganglionic parasympathetic fibers which are going to be part of the nervus intermedius, which is coming out of the cerebellopontine angle of the pontomedullary junction. Then they form the common facial nerve, and the common facial nerve has a geniculate ganglion. So at the geniculate ganglion, nothing, no problem when it comes to the submandibular gland. So beyond that, from the vertical part of the facial nerve, you get the cauda tympani nerve, and this cauda tympani nerve comes out of the petrotympanic fissure, joins the lingual nerve in the infratemporal fossa, and through the lingual nerve it goes and gives fibers that are synapsing with the submandibular ganglion, and from there it directly gives branches to innervate the submandibular gland. Now what happens if you are looking at the sublingual glands? It's the same pathway, absolutely same pathway, except that the nerve, the postganglionic fibers, they re-enter the lingual nerve and through its sublingual branch goes and supplies the sublingual gland. So it is the lingual nerve that is going to be responsible, eventually the fibers of the lingual nerve that are going to be supplying the sublingual gland and direct fibers from the ganglion onto the gland for the submandibular gland. Now let's look at the palatine glands. So here again you've got the preganglionic parasympathetic fibers which are forming the nervus intermedius. It forms the geniculate ganglion, and from the geniculate ganglion you get the greater petrosal nerve, which is a branch of the geniculate ganglion. The greater petrosal nerve joins with the deep petrosal nerve and forms a nerve, the pterygoid canal, and this nerve, the pterygoid canal, forms the synapse at the pterygopalatine ganglion. And this pterygopalatine ganglion, I already showed you, is found in the pterygomaxillary fissure of the pterygopalatine fossa. Now, from here the fibers travel in three different ways. So it forms the greater and lesser palatine nerves and supplies the palatine minor salivary glands. Then through the posterior inferior nasal nerves, it supplies the nasal glands as well as the glands in the nasopharynx. And then it takes a very complicated route to reach the lacrimal gland. So for the lacrimal gland, first and foremost, the postganglionic parasympathetic fibers re-enters into the maxillary nerve. The maxillary nerve has a branch called the zygomatic nerve, and the zygomatic nerve has two branches, the zygomatico-temporal and the zygomatico-facial. So these postganglionic parasympathetic fibers, they actually enter the zygomatico-temporal nerve, and this has a communication with the lacrimal nerve, and through the lacrimal nerve it supplies the lacrimal gland. So this is how the parasympathetic neurons that were found in the superior salivatory nucleus eventually supplies the nasal glands, the palatine glands, the lacrimal gland, the sublingual gland and the submandibular glands. Please understand this pathway, please revise this, and I think this diagram has relatively simplified how to make this diagram with the individual neural stations. So this is just a repetition of that for the pterygopalatine ganglion as well as the submandibular ganglion. Now this is something that is extremely important when it comes to neuroanatomy, that you understand that wherever your nerve fibers or nuclei are located, it is mandatory that you understand and know the blood supply of that region, because in neuroanatomy as well as in neurology, it works like mathematics. If you have the blood supply of a region that is blocked, you can predict what will be the features, that the patient is going to be developing, and vice versa. When a patient comes with a certain complex of symptoms or signs, you can immediately understand that which of the artery was possibly affected, and knowing which artery has been affected, you would know relatively what was the cause. And therefore, in this region, in the floor of the fourth ventricle, part of the medulla, you can understand that this lateral part, which contains the facial nucleus and the fibers of the facial nerve that are coming out, this region is actually supplied, you can see this, the solid orange color, by long circumferential branches of the basilar artery and branches of the anterior inferior cerebellar artery. Whereas the abducens nucleus and the portion of the internal genu of the facial nerve, the lemnisci, both the medial lemniscus as well as the spinal lemnisci are going to be supplied, and the corticospinal fibers are going to be supplied by, if you see, paramedian branches of the basilar artery, right? And the lateral part here, the lateral part which is containing the middle cerebellar fibers, middle cerebellar peduncle fibers, only the ventral part, this is actually supplied by the short circumferential branch of the basilar artery. Now, as you go up, you can see that mainly the same blood supply continues, except that when you reach the close part of the fourth ventricle as well as the midbrain, you also get branches of the superior cerebellar artery, because superior cerebellar artery lies under the stentorium cerebelli and is going to be supplying the upper part of the pons and the lower part of the midbrain. So this is the only additional feature that is going to be coming up. So please understand that you cannot learn neuroanatomy without knowing the corresponding blood supply of individual regions. You are going to have a class on the overall blood supply of the nervous system. That's a different matter altogether. But when you're learning individual parts also, it is mandatory that you know the blood supply or the vascular supply of that individual part. Now, coming to the clinical anatomy related to the facial nerve, it is one of the most frequently paralyzed cranial nerve among all motor nerves, but usually what you get is a lower motor neuron palsy, which is known as Bell's palsy, wherein one half of the face is completely paralyzed, and when that person has that paralysis, you can see that there is a drooping of the angle of the mouth, there will be lag of thalamus, that is, the person is not able to close the eye properly, as well as when the person tries to blow the mouth like this, there will be leaking of air from the side that is paralyzed. Why? Because the buccinator, which helps in sealing the mouth closed like that, is not able to produce a good sealing, and therefore from the side of the paralysis there is going to be leakage of air. So that is the typical lower motor neuron palsy. Now what happens in an upper motor neuron palsy is that the facial nerve nuclear complex has got an upper part and a lower part. The upper part is meant for the upper part, the muscles of the upper part of the face, and the lower part is meant for the lower part of the face. The upper part of the face, the supranuclear fibers or the corticonuclear fibers, which are coming from the cerebral cortex, that goes to both sides, both nuclei, and therefore even if one side corticonuclear fibers are damaged, the other side can take over, so the upper half of the face is usually spared. Whereas the lower half of the face, since it has only got a contralateral nerve supply from the opposite cerebral cortex, that gets affected, and therefore you get paralysis of the lower half of the face and not of the upper half of the face. So that is typical of the difference between an upper motor neuron lesion and a lower motor neuron lesion of the facial nerve. And this can happen either because of vascular problems or compression due to tumors or even demyelinating disorders. Okay? The lower motor neuron lesions are very commonly associated with parotid surgery. Why? Because you know that the peripheral distribution can be affected while operating on the parotid, because the nerve is actually traveling through the parotid gland. So that's it. If you have any questions, I would really appreciate it if you actually send it as an email to me, at tonygeorgejacob@gmail.com. So I'll just type that in right now. So if you have any queries, you may please send them to okay. So that is where you're going to be contacting me if you have any queries. All right. Thank you very much. I'll see you tomorrow, and I'll be dealing with the gross anatomy of the 5th and 7th cranial nerves. Close.